So thank you all again for joining. It's great to see some familiar faces, but also some new ones out there. So for those of you who are unfamiliar with our work, I'm just going to give a brief overview of what we do and of what we're going to talk about today. So I'll introduce Dr. Ann Cardile, who's here with us, and she will be sharing about her work at Unity Healthcare and about her time at Christ House as a year-long volunteer, or as we say, a YLV. After that, I'll start our Q&A, starting with questions that our ambassadors and staff helped to draft, and then moving on to questions from our audience. And so as we're going along, if you have any questions, just go ahead and put them in the chat, and then if we have time, we will get to them at the end. So with that being said, we'll get started. So Christ House is a medical respite facility for people experiencing homelessness in Washington, D.C. And our mission is to provide comprehensive and compassionate care for people experiencing homelessness with acute medical needs in D.C., and to offer assistance in addressing critical issues to help break the cycle of homelessness. So what is a medical respite facility? That means that when someone is too sick to be out on the street, but they're not quite sick enough for a hospital stay, they can stay in a lot of cases at Christ House. So some common reasons that patients are admitted include for wound care, recent or upcoming surgeries to either recover from or prepare for, patients who are undergoing cancer treatment, have a broken bone, all those good examples. And so during their stay, Christ House will provide 24-hour clinical care, 3 meals a day, case management support, lots of patient activities as well. And so Christ House's year-long volunteer program, or YLV program, it's a year of service where up to 7 individuals will live in community together and work in various roles at Christ House. And so our YLVs are a very crucial part of our work here and help us to carry out our mission every day. So this speaker series is an opportunity for us to hear from former YLVs about their time at Christ House, their current work, and most importantly, it's an opportunity to hear more about homelessness and healthcare from individuals who have made it their life's work to support our unhoused neighbors. And so if you ever want to learn more, you can visit our website, and I'll be sending lots of links at the end of this. But in the meantime, I'd like to introduce our speaker while you're all here today, Dr. Ann Cardile. So Dr. Ann Cardile is the medical director for the Healthcare for the Homeless program at Unity Healthcare, which is a network of community health centers in Washington, D.C., which serves 100,000 patients a year. Dr. Cardile's time as a YLV at Christ House helped establish in her the habit of service and helped educate her on the significant disparities in access to care, which can exist side by side in a city. Drawing on the foundation laid by her time at Christ House, Dr. Cardile has worked with Unity Healthcare for 17 years and is dedicated to expanding access to quality healthcare and social services for our neighbors experiencing homelessness. So now I will turn it over to you.
Excellent. Thank you so much. First, it's a delight to be here. Christ House is one of my favorite things, and at a time when things in the world are a bit more than topsy-turvy in so many ways, it's really great to come back to our roots and what establishes us, kind of like that tree planted by water that reaches out its roots into the stream to make us feel grounded and focused. It's also great to see a couple of folks that I know from my year. I was hoping maybe some folks would join, so I'm so pleased and so happy. I just wanted to take a moment to reflect together, and I'm really so privileged and honored and humbled to have this opportunity. Because as I said, Christ House is one of the foundational aspects of who I am today and the work that I do today, and that a work that I think a lot of us do today who've gone through the year-long volunteer program. To start with, it helps, as I mentioned in the little bio, it helps, I think, establish a habit of service. And I mean that in the very best sense. Like, we are developing habits every day, everything that we do. But going back to kind of the classical sense of what a habit is, it's virtues and vices are habits. They're choices and decisions that we make every day. And that beautiful habit of service are decisions that we make in small ways and big ways every day. And there was no better way in my life, certainly, to learn that than being a part of the community at Christ House for a year. I was there along with Mark Robert and others. Oops, did I just lose you? I just lost my screen.
We're still here.
Okay, great. I just lost my screen. Okay, great. But it was, believe it or not, for me, believe it or not, 25 years ago. It was 1996 to 1997, and I was a year-long volunteer in social services, social services department, and was with Brennan Neerman, who was so important also to helping establish my career in medicine. Like so many of us who go through Christ House, I think one of the things that draws us, and that we may not even know that we're drawn to until we get there and experience it, is that you are able to witness what it looks like to live out a life of service and love and action, and which in a way that is in so many ways apart from what our traditional materialist culture teaches us about. We are so wonderful in our country about competition. We're beautiful about that. We do that so well, and there are benefits to that. But the aspects of collaboration and reaching out to others is something that we do not necessarily thrive in some ways in our culture. And Christ House in that way is so beautifully countercultural and helps us develop those habits of service and attention to our neighbors in need that are a beautiful groundwork for the rest of our lives. As I mentioned, I was a year-long volunteer in social services. That was foundational to my understanding of beginning to really have a deep understanding of this social, what we now very, very glibly refer to as the social determinants of health, or what may be more accurately indicated as the social influencers of health. What are those things that people experience in their lives apart from medicine, apart from the medications they take, apart from their diagnoses, that deeply impact their ability to be successful and access care in a holistic and deep way. Those were some of the, I will never forget accompanying people to the Medicaid office, accompanying people to the social service administration, trying to help people get benefits that they qualified for, thinking, my God, what would I do if I had to do this by myself? And if I were, even in my fully active and fully fit mind and body person, what if I had to try to do this on my own? What if I had a child in tow? What would that be like? I've sat here hours and hours at this time. What would that do to my life if I had to try to do this on a regular basis to maintain care and access care? And that's just for me, again, what if I had additional people I was trying to care for? What if I was struggling with mental illness or substance use disorder and I was trying to navigate this? What would that be like? So those were some of those early visits that those aspects of accompaniment, which I think is so important for the year-long volunteers, to be able to see what it is actually like for individuals to try to access care in a city which as rich and as wealthy as DC is. What is it like to live, be a part of in a small way, to be in solidarity in a small way with those disparities that people experience? That was a deeply important part of my life, my year at Christ House, just walking in solidarity with individuals who were struggling and trying to access care. That is, I think, an important aspect of the year-long volunteers, Kira mentioned specifically how important the year-long volunteers are to Christ House, and it's true. You know, they do deeply vital functions, social services, nursing assistants, patient coordinators, activities coordinators, all these are deeply important. But the reality is, and this sounds trite, but it is so true, the experience of Christ House is deeply important as a foundational aspect of who we are, and who we become, and who we are choosing or forming ourselves. Because most of us, when we're there as, you know, I had just finished college, and I was wanting to go to, felt passionately about going to medical school, which can be, as many I'm sure know, a deeply angst-filled time. What is it like to experience being and witnessing people who have really dedicated their lives to the care of others during that period of time? It is deeply impactful. I'll never forget, toward the end of my time at Christ House, Mary Jordan, who hopefully many of you know, but you know, they're wonderful, many hats at Christ House these days. But at that time was mostly in the nursing coordination aspect. And I'll never forget her asking, you know, what my plans were, and I afterwards, and I was gonna cry. I really had a sense that I want to do this. This is something that's so beautiful, that really speaks to caring for those who are in the most need, who have been neglected in so many ways, but who are full, as we know and as we claim, are full of the dignity of humanity. And to reclaim that in a way that our culture might be very willing to discard because they're not seen as useful in a very competitive situation, but whom we know are deeply full of dignity. And to be able to reclaim that in a way that is also reclaims our own humanity at the same time. So Christ House was deeply, as I could go on, as you can see, for a long time, was deeply impactful, the experience. Okay, so where I am now. So let's think through, I was so grateful. I was certainly Christ House, my Christ House experience certainly helped. Was admitted to Georgetown for medical school, stayed on for residency in internal medicine, and then came out, and I was, as part of the National Health Service, was in a situation where I really not only wanted to, but actually the government was saying, you will be doing this, reaching out to work in a physician or a provider shortage area. And fortunately, again, those disparities are really highlighted the fact that a city as wealthy in clinician care, as wealthy in physician care as Washington, D.C. is still considered, because of the levels of disparity, to be a significant healthcare provider shortage area. So I again reached out to Dr. Getchus and was so thrilled that she said, yes, please come work with us. So that was, as soon as I finished residency, I started working where I am today, actually, which is the Center for Creative Nonviolence, or CCNV, shelter clinic, health center now, downtown in DC. Some of you who are familiar with DC will know it's a very storied, in many different ways, location in the healthcare, in the homeless community here in DC for a variety of reasons. But it really was one of the central points of the healthcare, the homeless protests in the early 80s, which were so important in helping to win some of the rights that individuals experiencing homelessness have today. And in expanding healthcare for the homeless, expanding some of the laws surrounding protection of those experiencing homelessness. So that was, gosh, almost 18 years ago now, which is just bizarre to me. But it was from there. So let's talk a little bit about Unity. Unity, our CEO, who's just resigned, who's just retired after 30 plus years, Vincent Keene, who was so wonderful, and who actually met Dr. Getchus, I learned, at this location at CCNV, 30 plus years ago. He said he always, when he was leaving, he said he always held it as a source of pride that, many community health centers or federally qualified health center networks add healthcare for the homeless, very appropriately so, to their services. But Unity here in DC grew out of healthcare for the homeless because of the foundation was so strong. So the healthcare for the homeless was an extraordinarily important part, and then the federally qualified health centers were joined onto it as part of that strong foundation. So where we are, I think of healthcare for the homeless here at Unity as typically as a three-pronged stool, which is part of related to what Christ House does. Our respite programs. Outreach is a huge important part. And then our community health center here in CCNB, which is, I consider as a hybrid between a community health center and a homeless outreach location, really much trying to establish a patient-centered medical home with a variety of services around it. Now, of course, in the pandemic, there's an extraordinarily fourth part of this stool, extraordinarily important fourth part of this stool, which is all of the tremendous work that my colleague Catherine Crossland and the team are helping to provide, which is the isolation and quarantine sites during these two good grief 2 years of COVID, and then in addition to that, really rethinking about how we think about congregate setting, and can we really move beyond congregate setting to locations that are more protective for individuals and to more single site based housing. And part of that program is the PEP Velo programs in the city right now, in the hotels, as you'll hear this referred to as. I'd like to think just for a second, and then I'll go from wherever is most appropriate. But I'd like to think just for a second, just for a couple minutes, about housing about homelessness in general. One thing to think about, I think about it in a very practical way, and I think of it in a more philosophical, social way. The practical way is that homelessness results simply from the economics of it. The lack of affordable housing. DC certainly, I think, ranks third in the least affordable housing for rental markets recently. So there's that aspect. Then there is the other. Then we have to think about poverty, and then we have to think about, of course, these last couple of years have taught us, if we weren't attuned to it before, the importance of the racial history of redlining, et cetera, that really affects wealth and poverty, this city in particular, and others, of course. And then I think about it in the philosophical or the social aspects. What are those things in our lives, in the lives of our families, of our community members, that force them out of the community, that force them out of housing? One of those is, of course, violence, and that can be in domestic violence, which is very important, especially for families, for all of our immigrants who are fleeing violence in their countries and in their communities. That can be a source of their homelessness. Then there's those things in our lives that alienate us from community, and I think about substance use disorder and chronic mental illness. Then there's those things that really cause us to potentially be rejected by our community. And unfortunately, we know that issues of the LGBTQ community are still significant in some areas of the country in this regard. But then increasingly, we're seeing those aspects of things. What happens when someone is no longer useful to somebody or to a community? And that community is under tremendous stress. So we're seeing individuals who are elderly and demented, who have significant medical issues, become a really regular part of our homeless community. Then we're seeing people who have lost those supports of their community. Those are individuals, for instance, who have aged out of the foster care system, or the ones who, for instance, who were vulnerable adult who have been cared for all of their life by a devoted parent, and then that parent dies and they don't have the appropriate resources in place, and they fall through the cracks and end up in the shelter as a vulnerable adult. So there's lots to think about, and I particularly I feel very passionately about the issues of mental illness because it's part of my own family's experience in regards to housing or near homelessness or near homelessness, and I can speak a good while about that. But I think I'll pause here, and I think I'll pass it back to Abby. I think, is that right?
Yeah. So I can take over for our Q&A now, getting to ask some of those questions that we had prepared. Thank you, first of all, for the background and everything. I think it's really helpful to know, and appreciate you sharing, your personal story. So to jump us off, we can combine a couple questions into one. How does Unity Healthcare help tackle the healthcare disparity? You've touched on this a little bit. Sure. And then also, how has that disparity issue changed since the beginning of your career?
Sure. And there are a couple of things, and this is one of the things after working at Christ House, it became very clear. I was very clear in my own mind that I never wanted to work anywhere that didn't have social services as part of what they were trying to do medically. Because if you look at social determinants of health, some percentages, statistics suggest that 80% of what we're trying to deal with in issues of health is really regarding social determinants or social influencers of health. And so to try to handle those things medically in abstraction just doesn't make sense as to who we are as human beings, especially individuals who have experienced a ton of trauma. So that's one of the things Unity has done and continues to do from the get-go, and certainly as Christ House certainly does, is look at individuals as a whole, which is deeply important. And so that includes making sure that there's integrated behavioral health and also social services at all of our locations, because it just, there's certainly folks who don't need that, but I don't interact with many folks like that, and I don't know many folks like that, quite honestly. I think social services and integrated behavioral health is deeply important, and that's something that Unity is in part of. And gratefully, most federally qualified health centers are involved in that as well, that type of work. The last thing I'll say, or I'll just say one other thing here, is I'll mention that about 15 years ago exactly now, Unity helped expand care to the Department of Corrections in DC, really changing the model to understand that these are individuals who are displaced members of our community rather than inmates, criminals, et cetera, et cetera, et cetera, which is also, I think, a deeply important way of thinking about our community. And I think Unity does a wonderful job about that, with that. I think I'll stop there.
Thank you. And then another bigger question, how does DC compare to other large cities in tackling these issues? Are local solutions like Unity the answer, or do we need fundamental change federally?
We definitely need change at all levels. The one thing I've always been grateful for working in DC has to do with that liberal social service network, or for instance, for healthcare, we have just about everyone who's 200% or below of poverty qualifies for healthcare, whether or not they're whether or not they have the right paperwork, if you will, or not, which is a deeply important part of accessing care. But there are so many complex issues surrounding issues of homelessness, and this I'll touch on one of the aspects and this is not just DC, this is across the country, are how do we really, and again, this is one of the things I'm very passionate about, how do we attend to those who are in mental health crisis, ideally before they're in a mental health crisis, when it's clear that they're getting to a mental health crisis, and early. Because, for instance, things like schizophrenia, bipolar disorder, so often they are, they manifest late teens, early 20s. And if you're in a community or a family where people are under deep, deep stress, importantly, where there's limited resources, specifically appropriate hospital beds, where people can be appropriately admitted for the care that they need, much like someone who was having a heart attack. People need to be in care, and they need to be in care for more than a few days. Those types of interventions are needed throughout the United States, because we do not do that well as a country. And it is something that would be impactful not only for the individual, but I speak of this personally, and I know this directly. It is deeply impactful for that person's entire family and for that family's that network. Because if you take a young person who is developing schizophrenia, schizoaffective disorder, whatever, and you give them the care that they need, and you give them the support that they need, that helps impact the stability of all of the other children in that family, of the parents, of the extended family, of the community. So to be able to have those resources, which are deeply short at this time in our country, and we can go into why that is, but those are deeply important things for us to have, and that requires change, that we are not alone in the fact that we don't do it well, but we don't do it well here in DC, because it's something we don't do well as a country. And I think just taking one aspect, I think I'll start with that, how we address mental health crises and the mental health bed availability in our country. I could go on, but I'll stop.
Thank you. Yeah. And then somewhat related to that, how can these solutions be applied? This is from a participant across the river in Arlington. I don't know if you have specifics, but.
There is, and I'll speak now. Now I'll go back to a second about there are the interventions that are. I'll speak kind of. I was reading recently about what's his name? I think he went by Nuri. No, it wasn't Nuri. Nye Bevan, who was the Welshman who was Minister of Health when the National Health Service in Great Britain in the UK was established. And he went back to his own Welsh, I forget the town, we're gonna murder the town because it's Welsh, the name of the town, but they had a system in place that was working really well, where people were involved. And he said, you know what, I think we could probably nationalize this. This is such a good idea. All that to say that there are good things that happen locally that can be, that can influence things nationally. But that's a long-winded way of saying that one of the important things that's happening locally here in DC, and Christos is the best example of it, is the importance of having respite care available for individuals who are experiencing homelessness. Because that is a way to help break into the cycles of homelessness, is to make sure that individuals who are in need of medical care and who are experiencing homelessness have an opportunity to heal in a safe and appropriate place. As I say, Christos is probably the best example nationally because it's so comprehensive and so dedicated. And most places just don't have the ability to do that with that level of dedication and sophistication. But even smaller programs, shelter-based or otherwise, can do a significant good, and that's something that can be implemented in every jurisdiction, especially when you alert folks either at the hospitals or the folks in administration that it's actually a very good cost-effective thing to do as well, is at least at some level, to help prevent rehospitalizations, et cetera. So I'll stop there.
Yeah, thank you for that. And then pivoting a bit here, thinking more about COVID-19. So thinking about what the impact of COVID has been on your work. And then also a follow-up question of how many people experiencing homelessness we still have in pandemic emergency hotels, and how long DC will be keeping those open for people who need them.
Yeah, no, thank you. So as I say, the past 2 years, I mean, it's been rough, right, for everybody. So it has been we've had to shift extraordinarily over the past couple of years. But I do like, and one of our mantras has been never waste a crisis, because there are good things that come out of this if we are open to change and open to new ideas. So, but just to start with, March 2020, I think of, going to those, the hotels, the isolation and quarantine hotels, empty beltway. I live just outside the beltway, but empty beltway coming in, and on the top of the I think they're called the stanchions, the electric lights on top of the beltway, saying, stay home, keep 6 feet apart, cover your cough, wear a mask. And it was really a moment of, it was just deeply, deeply painful and frustrating, because most of our individuals who are in congregate setting, this is just something they do not have the ability to control. When the vaccine came out, which was huge, obviously, and we were doing town halls, many town halls in the shelters, I'll never forget an experience I had at one of our large men's shelters. And this was after our, fortunately, again, one of my colleague, Catherine Crosland, who's been so wonderful in thinking through this and helping the city lead the city through these things. So she had helped think through, we really need to get people de-densify the shelters. And this was even after, and so these special programs like the PEP-B, which were mentioned. So not only the isolation and quarantine sites for those who were positive or who were exposed, but to help proactively remove people from the shelters, especially those who are at the highest risk for poor outcomes. But so all that's to say, this was the vaccine town halls were after that, after many people had been working to de-densify the shelters. And I was in one of the large men's shelters, and I was, there's something that happened, and we had to kind of go from dorm to dorm to talk about the vaccine and to help build trust in the vaccine and that type of thing. And it's an image I'll take with me for a long time, and just how crowded it still was, how close together people still were, even after the efforts to help de-densify the shelters. This is still, and how anyone, especially before the vaccine, how anyone in those situations could protect themselves. It was just deeply powerful, the image in my mind of that dorm room. So all that's to say, the never waste a crisis aspect of this is people really thinking through, this congregate setting, maybe this isn't the best idea. Is it needed? Yes, it's needed to a certain extent, but what can we do to really have better solutions? And so continue to think through that.
Yeah, thank you for that. And then next, another question from a participant. As an inpatient medical provider, what support can I offer to patients experiencing homelessness?
Yeah, and I think those are so, I think that too, the aspect of when we're in the hospital, we're always thinking about disposition, like where's this person going to go? So, and I think those are some of the important things, you know, right away, is to think, and this isn't going to be new to this or shattering to this person, but to really, as soon as someone is identified as experiencing homelessness, to see if to get social work involved right away, to see and to maybe think, are there locations like Christ House? The other silver lining about the Never Waste a Crisis aspect of the ISAC, isolation and quarantine piece so far, is looking at ways to expand respite throughout all of this. Not to the level of Christ House, because only Christ House can do what Christ House does. But those important aspects of how can we expand at a lower level respite care, and what my colleague, Dr. Hawthorne, Jen Hawthorne, has been really helping, again, lead the city through some of these discussions as well. And it's been deeply important. So looking around for thinking through, if this person is experiencing homelessness and you're in the inpatient, where are they going to go? And is there a better option for them to go than beside the street, or back to a regular shelter?
Yeah, thank you. And then another question from a participant who is curious about policy changes that would be most beneficial for increasing healthcare access for individuals experiencing homelessness.
It's interesting. I know one of the things, and I'll certainly share anyone who, the National Coalition, the National Healthcare for the Homeless Coalition, their most recent policy brief, which comes out, it has been, I think, it comes out about once a month, is looking at some of the things right now as far as with the end of the emergency and some of the Medicaid, the things that have been automatic, like those Medicaid renewals for people, which are now potentially going to be interrupted because we're the official end of the emergency. So those are some things right away, even like right now, to think about reaching out to say, hey, does this really, you know, we did this, maybe there's a better way, maybe we don't have to waste this crisis. Maybe it makes sense to have people automatically renewed rather than sending out a random paper letter to somebody, you know, that they may or may not get, especially if they're experiencing homelessness. So to think through some of those policy changes as far as how people, even something very practical, like how Medicaid is renewed for individuals. So that's one thing that just off the top of my mind. Yeah, that's just, again, and again, I'm happy to share. I know, Kira, I know you have links too, but I have some too that to share with folks afterwards if they would like any connections in that regard. Because again, the National Healthcare for the Homeless Conference has a wonderful policy, as does, I know, also Salma and Marion's Kitchen have wonderful policy.
Yeah, I will definitely get that from you and then share it out. Thank you. Another question. Why aren't there more respite care facilities, and what is it about Christ House that allows it to offer such a broad range of services, and how can that be replicated? Right.
Well, there are a few answers to that. One, it takes money, quite honestly. You know, we're all yearling volunteers, but as they would used to say, we're not free, even as yearling volunteers. So because there's healthcare, there's et cetera, there's housing. But so it takes a lot of money to do what Christ House does. And there have been a limited level of reimbursement at various levels. So that would be at the Medicaid levels, about as far as how people can be reimbursed for respite care. There's also the question, like, gosh, what do you do if someone is uninsured and you can't bill at all? What does that look like? Forgive me. So I know, so there's, and to do it really, really well, to understand that we're human beings and have complex needs, and to help create community and to help heal of those issues of addiction and that type of thing, that takes even more expertise and more levels of care. And that is something that, again, Christ House does very, very well. But again, it takes money. And I know Christ House not only, has multiple fundraising streams to help accomplish that, but that takes work. And it takes people, generous people to do it, to recognize the dignity of their neighbors and to continue to give in that fashion.
Great, thank you for that. Just a couple more. What has been the most challenging and the most rewarding parts of your career?
Sure. And for me, it's a no-brainer for me as far as the most challenging, and that I've alluded to already, and it has to do with our how we treat and how we're able to engage or not engage individuals who are seriously mentally ill, because that is to say somebody isn't just to kind of wipe our hands of that person because they're not interested in care, when we have to question their level of volition. It's just very painful, and they're just at this point are not the level of resources that we need or the will to change how we do that, and that so we continue to fight and to advocate, but that is without a doubt that is the most painful thing, to see individuals on the street who we know are deeply alienated from everything. That is deeply painful. Most rewarding, I was reflecting. I started Christ House in 1996, my Christ House year, and that was a year of the first officially highly effective antiretroviral combination. So to see HIV become a chronic disease is deeply satisfying. To see hepatitis C cured is deeply satisfying. But again, that's with a caveat that the folks who don't, especially with HIV, who still struggle with ongoing poor outcomes, needlessly so, are those who are experiencing homelessness, who are experiencing chronic mental illness, and are experiencing substance use disorder. So those are to see those evolutions in care has been fabulous and rewarding, with that caveat that continues to have it be a sober reality.
Mm-hmm. Yeah. And then what steps can the average person take to help this ginormous intersectional issue,
Sure.
homelessness and access to care, and what are the most pressing needs and issues?
No, and it is absolutely intersectional. There's no doubt. And I just saw that the policy advisor there's the U.S. Interagency Council for Homelessness chose a new head, and the idea, I think it's like 17 different agencies involved, because it is so deep and so intersectional. But I go back to, for those things that the two aspects of what we learn, and what we learn at Christ House, and what we learn in any of our hopefully in any of our service opportunities. And one is that there's the aspect of relation and knowing individuals walking in solidarity with individuals in whatever way that is, but that is a face-to-face connection with somebody who is struggling, and that can be remote, or that can be in person. So to be able to hear the stories and to share and to know that these are realities that people are experiencing. And then on the other end, the other hand to that are the policy issues, and how can we work to create a more just and a more equitable society. And so I think being involved in those two aspects, in whatever way that we are called to, in whatever way that we are capable of at the various stages of our life, that direct connection, and then thinking about what can we do as a society, as a community, to make things better.